Good afternoon, everybody. Welcome to this webinar that is being sponsored by RIATT. My name is Lisa Langhow, and I'm the head of research at REPSI, and it's a pleasure that you're all here. We're just to give you a couple of keys on how to work the system. You should have a set of slides on your screen. If you move this, yeah. And if you're new to webinars, the way that this works is that we have today with us, we're honored to have three panelists who are going to be speaking with us about their research, which was sponsored by RIATT. And questions that you have, the attendees will be muted, and so the questions that you want to ask to the panelists need to be asked through the questions chat box. In addition, I would like to ask each of you to think about, as programmers and as researchers, but particularly those of you who are in programming, RIATT and REPSI are very interested in finding out how you would use the data that's being presented today in your programming. So if you could not only ask questions of the panelists, but also make sure that you are thinking about, as the research is presented to you, how you would use the data in the field, in the work that you're doing. Please note that this webinar is going to be recorded, and it will be posted on the RIATT website probably in about 2 weeks' time. And since you signed up for this webinar, you will get an email letting you know when the webinar is online and up on the website. And then you can send that to other people who weren't able to attend to let them get information from this webinar. Okay, so I'm just going to introduce Naomi Coupe to you now, who is the program manager for RIATT, who's going to give you a little bit of information about RIATT before we get a chance to talk to our three panelists.
Welcome, everybody. My name is Naomi Coupe. I'm the program manager for RIATT-ESA. RIATT-ESA is the regional voice for children affected by HIV and AIDS in Eastern and Southern Africa. What we did is that in 2013, we got together with the researchers that are on this webinar to conduct research that ultimately seeks to improve outcomes for children. We then produced a series of policy briefs which are available on our website, which is www.riattesa.org. Please check them out. Without further ado, I'm going to hand back to Lisa, who's our chair.
Thank you very much, Naomi. We have, as Naomi mentioned, there were four pieces of research that were commissioned by RIATT, and of those four, three of the presenters are able to come today. Unfortunately, our colleague from Uganda, Dr. Fred Makumbi, couldn't make it to this presentation, but his slides will be available on the website, and his policy briefs are on the website. So today we have the privilege of speaking with three individuals. One is Dr. Francesca Menk, who's going to be talking to us from Oxford. Then we will move on to talking with Dr. Simon Gregson from Imperial College about some research in Manicaland. I'll introduce each of them before they speak. And then Sarah Skeen, who will be talking to us from Stellenbosch. So first off is we'd like to introduce Dr. Francesca Menk. She is from Oxford University and working on a part of a project that's a large cohort study in South Africa, one of the largest in the region. And she's providing us with information about the relationship between cash and care and prevention and adherence with adolescents. So this is really exciting data that's been well presented, that's been shared widely. So I'm going to hand it over to Franny.
Great, thanks. Thanks for the introduction. I just want to say I work with Lucy Kluber, who you probably all know, and I'm basically presenting on her behalf today. Next slide, please. What I'm talking today is about a collaborative research project that we have been carrying out in South Africa. This research project is together with the with some South African government departments, with UNICEF, the World Health Organization, Save the Children, UNAIDS, PEPFAR, USAID PEPFAR, REPSI, and local universities, obviously Oxford and Curtin University in South Africa. And we also have a teen advisory group who you can see at the very bottom there, who are informing our research and are telling us what kind of questions are important and applicable to their lives, and how to phrase the questions, and how to design our questionnaires so that children enjoy participating in the research. Can I please have the next slide? What I'm presenting today is part of a longitudinal study, or results from a longitudinal study of adolescents that we've carried out in South Africa. The data we're looking at today is from 6,000 adolescents who were interviewed in 3 provinces across 6 sites where HIV prevalence was above 30%. We used random sampling of census enumeration areas. Every household was interviewed that had a child aged 10 to 17 within these areas. And we followed all of these children up a year later, but only in 2 provinces because we ran out of money in the 3rd province, and we managed to get 97% of them, so that's pretty good. We used standardized scales, national surveys to measure all of the types of outcomes that I'm going to be talking about today, and we've got ethical approval from a lot of departments and universities. Thank you. One of the questions that we've been asked is whether there's anything that can reduce incidence and prevalence of transactional sex and age-disparate sex. And the analysis that you can see here has looked at transactional sex and transactional sex on the left-hand side and age-disparate sex on the right-hand side. And what you can see is that for girls only, unfortunately, child cash transfer, or the receipt of a child cash transfer, can reduce the incidence of transactional sex by half, and can reduce the odds for age-disparate sex by 70%. So that's pretty good result, but it doesn't work for boys. Can I have the next slide, please? So we've been thinking about looking at cash and care as interventions to reduce incidence rates of transactional sex, age-disparate sex, sex using multiple substances, sex with multiple partners, unprotected sex, and teen pregnancy. And these are different. Thanks. These are different types of sex. So what we call careless sex and starving sex, so sex that you have to do because that you have to engage in because your basically economic means have you engage in it, or careless sex, stuff like unprotected sex or using substances. The care and cash types of interventions that we've been looking at, you can see in this slide. The cash type stuff is food gardens, child-focused grants, food parcels, free school meals, and the care type interventions are positive parenting, school counseling, and teacher support, and you can see them on the right side. So we've, can I have the next slide, please? So we've looked at whether cash and care have an impact. And if we remember from the 2 slides before, for girls, cash about halved the odds for engaging in transactional sex, or in engaging in risky sexual behaviors. And we can see the same here. But if we use cash plus care, or combine cash and care, we can see that we get an odds reduction by half, again, for girls. And for boys, where cash, on the right-hand side, where cash didn't do anything at all, we can see that cash and care together also give us an odds reduction of 50%. So cash and care are very powerful. Can I have the next slide, please? But then we've been asked what kind of interventions address what types of risky sexual behavior. And what you can see in this picture, basically, or in this slide, is that for boys who are in blue, we can see that free books and free schooling has an impact on, reduces their risky sexual behavior when it comes to careless sex. And parental monitoring reduces also their risky behavior when it comes to careless sex. For starving sex, we can see that monitoring has a huge impact on whether boys engage in sex because of economic necessity. And for girls, we see a slightly different picture. We can see that school feeding schemes and parental monitoring impact on careless sex, so the kind of sex that you're having because you're a teenager. And starving sex is impacted by child grants and free school and books. Can I have the next one, please? So we've looked at combinations of whether combinations have additive effects of in reducing risk behaviors. And for boys, we can see that that free schooling and good monitoring reduce incidence of careless sex, and both interventions together are much more effective than either one of them alone. If we look at the next slide, when we look at girls, we look at starving sex, so sex out of economic necessity. And what we can see is that child grants and free schools both impact on incidence of starving sex, but both interventions together have a much bigger impact. Can I have the next slide, please? And for careless sex in females, we can see that monitoring and school feedings both have a slight impact, but both interventions together, again, reduce the risk quite considerably. Thank you. Thank you to our funders who are on the next slide. Just to sum up, on the next slide, we can see that unconditional government cash transfers reduce adolescents' HIV risk. We can see that cash plus care gives greater effects, and cash and care mitigates structural risks. But we can also see that the more types of interventions you have, the better, the higher the impact, and that these are effective in real-world sub-Saharan Africa. Thank you.
Thank you very much, Fran. That was excellent and really, really useful information about the relationship between cash, but also how cash and care together have such a powerful effect. And so I want to thank you. And I'm hoping that our attendees on the webinar are taking note and thinking about ways that they can use this in their programming, because that would be useful for all of us to share and learn from together as a group. I would like to now turn our attention to Dr. Simon Gregson. Simon and I have known each other from Imperial College. He was one of the first people that helped introduce me to different ways of collecting data and spurred me on to write my PhD. So a nice thank you for him, and I've known him for a long time. The data that Simon is going to be presenting to us today is around work that's been done on a long study that's been going on since about 2003, a cohort in Manicaland in Zimbabwe, which is in the mountains close to Mozambique. And he's going to be looking at the determinants and benefits of school enrollment for orphans and vulnerable children in that part of the world. So thank you, Simon, and I'll turn the floor over to you.
Okay, thank you very much, Lisa, for the kind introduction. So this work has been done by a lot of people, and the presentation in particular, and the analysis, secondary analysis that's being presented here was mainly done by Erica Pufal, Laura Robertson, and Constance Nyamakapa. I'm the person who's available today, so I'm happy to be presenting it. So as Lisa said, this is we're looking at data from Manicaland, which is the eastern province of Zimbabwe. The data are from a population-based open cohort in rural eastern Zimbabwe, which actually started in the late 1990s. So the main data source is this general population open cohort, for which currently we have 5 rounds of data available for analysis to cover the period 1998 to 2011. In the most recent round, 2009 to 2011, we extended the eligible age range to include children aged between 2 and 7, or 2 to 14, which means we've got some children included there between the ages of 2 and 17, so about 4,000 children in that age range. Between 2002 and 2006, we did a linked child cohort survey, which is a kind of smaller study of about 763 children of school-going age 6 to 18 being enumerated at baseline. And then again, more recently, between 2009 and 2011, we conducted a community randomized control trial of conditional and unconditional cash transfers. So we have some data about 8,000 children between the ages of 6 and 17 participated in that study. So the studies done for RIATT comprised, we were asked to give them some money to do some secondary analyses of data that we'd already collected in these various studies. In this particular slide, we can summarize some of the findings from earlier studies that we've done in Manicaland, but also from wider research that's been done in Zimbabwe and other parts of the region. So very briefly, it's known that education outcomes can be negatively impacted by the loss of a parent, having an HIV-positive parent, or having a parent who's chronically ill. But the mechanisms through which orphanhood and vulnerability affect school enrollment and education outcomes are not fully understood. Interventions, as been shown in the previous presentation and elsewhere, including cash transfers, can increase school attendance and reduce HIV risk. And education is known to decrease HIV risk, particularly amongst young women, but the mechanisms through which this occurs are not completely understood. And in particular, decreases in substance use, which may be associated with less risky sexual behaviors, could be one way in which education decreases HIV risk. Okay, next slide, please. Okay, thank you. So this slide here just summarizes the main research findings. So for the RIATT project, we carried out 2 additional sets of secondary analyses, one looking at the determinant of school enrollment and attendance, to looking to see whether migration affected school enrollment, and the second looking at an effect or potential benefit of education to see whether being enrolled and attending school might reduce substance use, and particularly substance abuse. So for migration and education, for this analysis we used data from the 2nd and 3rd rounds of the child cohort study, which covered the period 2002 to 2006 for children aged 6 to 18 years. We found that 11% of children migrated between the 2nd and 3rd rounds, which was a period of just over a year. The children who moved household were at 7 times greater risk of dropping out of school compared to those who didn't move household, with the risk being highest for children who moved longer distances, who moved away from their original home area. We found that migration did not result in higher school dropout in OVCs compared to non-OVCs, but maternal orphans, or orphans in general actually, were more likely to migrate than other children. For maternal orphans, these children had 4 times greater odds of migrating between survey rounds compared to non-orphans, whereas for other types of orphans, those who'd lost their fathers or both parents, there was also an increased risk of migrating, but the differences were not statistically significant. In these particular data, there was no association between orphanhood and school enrollment, but in previous analyses of larger data sets at different time points in the epidemic, we have found such an association. So it's quite possible that more frequent movements between households may explain these previously observed associations between maternal orphanhood and non-enrollment, given the findings of this particular analysis. Secondly, moving on to the results that we got for education and substance use. Here we were using data from the child survey, which was conducted between 2009 and 2011, focusing on children aged between 15 and 19 years. For boys, 6.4% reported use of alcohol, 3.2% use of drugs, and just under 1% reported smoking. And for boys, male orphans were found to be at increased risk of drug use. In particular, maternal and double orphans had 2 times higher odds compared to non-orphans of drug use. There was no difference for children whose fathers had died, and for other substances, in other words for alcohol and smoking, there was a trend towards higher levels of drug use, but the differences were not statistically significant. Okay, the next finding, sorry, come back again to the last slide. Haven't quite finished. Okay, so we also found that school enrollment was associated with lower substance use in males. So So the boys who were enrolled in school were less likely to be using these substances. But for girls, substance use was rare, less than 1% in female OBCs in Manicaland. Sorry, I might have missed this out. So school enrollment amongst males, that the males who were enrolled in school had almost 3/4 lower odds of reporting use of drugs, 2/3 lower odds of using alcohol, and 3/4 lower odds of using of smoking, and there were similar patterns for orphans. So we conclude from that education, being enrolled in school, may moderate the relationship between parental loss, substance use, and sexual risk behaviors for HIV infection. Okay, next slide. So we were asked to suggest some recommendations. I'd be a little bit cautious about these because we want to emphasize that these need to be taken together with findings from other studies in Zimbabwe and other parts of the region. The results may be context specific, both in terms of the place where the research was done and the time, the stage of the HIV epidemic in which the research was done. It's quite possible that the kind of relationships might be a bit different in the last 2 or 3 years since antiretroviral treatment has been scaled up. But with that kind of cautionary note, it would seem, based on these results, that interventions or further interventions may be needed to ensure that children who move household are identified and re-enrolled in school in their new place of residence where that's appropriate. And it seems to be important to help families to understand the negative impact of household mobility and to help them reduce this household mobility, to try to stabilize households and minimize the extent to which children are moving around between different households, because that can be disruptive to their education and as a consequence can have negative effects. On education and substance use, increasing school enrollment further could be a way to decrease substance use and abuse amongst OBCs, particularly for boys, which then could have the potential to also further reduce HIV risk. And the findings demonstrate another potential benefit of education, particularly for male OBCs, that could be used, or the kind of emphasize the potential benefits of cash transfers and other programs that increase school enrollment and attendance. Okay, we're asked to identify a couple of broader issues that might need to be addressed arising from the research. Perhaps further consideration needs to be whether, given to, we've seen some positive effects of education both in these analyses and other analyses that we've done for OBC, but obviously there are other approaches. So to the extent, the question is where can further funds be found to invest further in education, and to the extent that there are funds available, what should be the right balance between investing in further initiatives to increase education enrollment as opposed to other potential uses of that money. And focus particularly on education, what's the right balance between interventions such as cash transfers, which address kind of supply side, demand side considerations, as opposed to further support for schools directly, which would address the supply side. Are the two mutually exclusively? I suspect not. Or can funding be integrated synergistically to promote education? If we think about cash transfer funding, there's an increasing emphasis on using cash transfer funds, cash transfers to assist girls and female OBCs, whereas we've found in the results here that can also benefits for boys, particularly in relation to substance use. So the question of if there's a shift of emphasis towards including boys more, does that necessarily mean that girls would have to lose out? Okay, final slide. Okay, we also asked one or two suggestions relating to the future. So clearly school education can play a vital role in halting the spread of HIV/AIDS through a variety of avenues, including kind of addressing the mechanisms that we've identified in this particular piece of research. And the second point is perhaps fairly obvious, that knowledge of HIV transmission routes remains fairly limited amongst young people. And I suppose there's a danger with the scale of antiretroviral treatment programs that there may be a bit of possibility that we might take our eye off the ball here, but clearly HIV education programs in school are an excellent way of making sure that young people have the right information. But to achieve this, it's clear that children have to be, obesity in particular, have to be in school in the first place to benefit, to achieve those benefits. Thank you very much.
Thank you very much, Simon. That was an excellent presentation and makes us think really carefully about the role that education and migration can play. I know in the research that we were doing in the RIATT-ESA trial, we were interviewing qualitatively one young woman who had moved 5 times in the last 7 years, and every time it was as a result of her primary caregiver passing away. And so she had moved house a lot, and the data from her was very powerful and spoke similarly to what you're finding as well. So that's really important. Before I turn to our next speaker, which is Sarah Skeen, I just wanted to, we've got 2 questions for Fran. And Fran, I just want to read the questions to you so that you have a chance to think about them while Sarah is speaking going forward. So the first one says, your research indicates no effect of cash grants only on boys. Is it possible that the effect could be negative? That is, if the boys have money, they could be more tempted to get sex from girls, given that they can afford to get girls from the girls that they're getting with cash in exchange. And then the second question, also for Fran, is thanks for our presentation. I have a few follow-up questions. How long was the intervention? And would you say the duration of the intervention has an effect on the outcomes? So there just seems to be clarity that this wasn't an intervention. If so, how? I'm also interested to know whether or not the cash support was conditional and what your thoughts are regarding conditional and non-conditional cash. If your intervention offered conditional cash, I would like to know what these conditions were and whether you think the outcomes would be different if you had a different set of conditions. Okay, so I'm going to now turn to Sarah. I'm going to introduce her. Next slide. Yeah. So this is an opportunity to introduce a colleague of mine, Sarah, who I've known for a couple of years, and we were very involved in the logistics of starting up this project, and I was always impressed by the cool and calmness that Sarah put to this task of collecting data in several different countries from a lot of scattered NGOs around the region. So Sarah, you're going to get a chance to talk to us and share information from the literature review that was done that looked at the importance of community-based interventions and had their role in improving psychosocial well-being of children affected by HIV and AIDS. So over to you.
Thanks, Lisa, and thanks everyone for the opportunity to be here today. Can you hear me? Yeah. I'm part of a bigger team, and the names are all listed there that you can see. So we work together. I'm from Stellenbosch University. I work with Mark Tomlinson, and we work together with Lorraine, who's also online at the moment, and Natasha Kroom did a lot of work for this as well. Just quickly, the project that Lisa mentioned is called the Child Community Care Study, and that is kind of some additional work that we did in conjunction with this systematic review that I'll be talking to you about, but I'm happy to answer questions on that as well. Basically, what the state of kind of funding in terms of OVC programming is that there's a huge amount of money that's actually going into these programs, although often it feels like it's a neglected area, or there's, particularly mental health, global mental health, often we would talk about there being limited funding for mental health programs. The reality is that there's actually hundreds of millions of dollars going towards OVC funding and for psychosocial support programs for children affected by HIV. And just a couple of statistics that I've pulled out there. You can see that there was more than $100 million, it was in 2009, that was going for vulnerable children in Uganda, and that about 15 million children were enrolled in PEPFAR programs for orphans and vulnerable children in 2012. So you can see that there is funding behind these initiatives. Thank you. And a lot of that funding is actually going directly to community-based organizations, sometimes through larger NGOs, but ultimately arriving at the doors of community-based organizations that are running these programs. And there's a lot of reasons for this, and there's been a shift towards these community-focused approaches over the past decade. And some of the reasons are here. First, of course, a lot of these children are living in communities where there's a shortage of health workers. A lot of these organizations are more likely to be able to access the very marginalized children and families in these communities, for example, by going and doing home visiting, not just seeing children at clinics or hospitals or through school-based programs. There's a belief that these community organizations are more sustainable than external interventions that are provided by partners that aren't part of the community. So there's a lot of very good reasons why these community organizations are running these programs. But unfortunately, at the same time, there's been a lot of investment in these programs, but there hasn't been a lot of investment in evidence to see what actually works to improve the lives of the children that are attending these programs. And this was really highlighted in 2009 when a lot of this work started in terms of our team. There was a Cochrane review that was done in that year, which is basically a review where they looked at every published study that had been evaluated to a kind of good quality level, and found that there were actually no studies that they could identify that looked at psychosocial programs for children affected by HIV/AIDS and came up with a result, a negative or positive result, that was something that we could learn lessons about how to develop our programming using evidence. So that led to a number of calls for increased investment into evidence-based programming. And as a result of that and some other initiatives that happened around the same time, there's been a prioritization of trying to evaluate these psychosocial interventions that children are receiving and really prioritize this as an issue amongst funders. Next slide, please. Okay, so that's just a picture from one of the organizations we were at, but next slide, please. So in 2013, we were awarded this grant to update the review, and we're still busy converting it into a Cochrane review, which will hopefully be complete in the next couple of months. And as a part of this review, we looked at papers that were published in the 4 years subsequent to the original review. So we relied quite heavily on the original Cochrane review in terms of the methodology. And then we looked at the subsequent 4 years to see if there had been any increase in evidence generation during that time. We made a few changes to the methodology. For example, in the original review, studies that only relied on carer report data were excluded. So, for example, if a study asks a mother questions about their child's behavior or health outcomes, it wasn't included in the original review. So we decided to include those. And in addition, we didn't look very closely at whether or not a child there was a criteria in the original review that at least 80% of the sample had to have a parent with HIV. And we found that in most cases in the research, it's not very well documented whether or not that's the case. So we didn't include that criteria for our review. And we did look for studies from both high and low income countries. Next slide, please. And this is just to show you a bit of the methodology. We had a whole range of keywords that we used. We searched a number of different library databases. And then from that, we had several thousand articles, which were reviewed by 2 reviewers. And then we included studies and sort of whittled down this long list of studies. And we looked at the design of the studies, what kind of participants they had, the types of interventions to make sure they fit our criteria, and also the types of outcomes that were measured. And we came up with 18 different studies that had taken place, or 18 different papers or publications that had taken place. Next slide. But which actually, as we found, although there were 18 reports or publications, they actually were linked to 11 studies. So some of the studies had reported the same results, similar results in more than one place. And we found some quite promising results. So, for example, almost every single one, 12 studies. So 11 of the 12 studies had taken place in 7 different low and middle income countries. And there was one study which had taken place in a high income setting. So it was encouraging to see that the research is taking place where it should be taking place, where the burden is the highest. And actually all of the studies except for 2 of them were in Southern African countries. And 7 of the studies were randomized control trials, which is the gold standard for research and measuring intervention, so that's also encouraging. One thing that was interesting to see is that actually only 10 of them out of the 12 were developed specifically for research purposes, and only 2 of them were evaluations of existing and ongoing programs. So it's really highlighting this issue that the actual programs that are going on out there and serving, for example, those 15 million children, those are still not the programs that are being evaluated. So the programs that we're finding now are ones where they are using, perhaps delivering interventions through NGOs and through community-based organizations, but specifically for research purposes, and not, it's not an evaluation of their general everyday service that they may have provided. And you can see there's quite a mix of different types of interventions, some psychosocial interventions, 1 physical medical intervention, 2 psychological interventions, and 4 social interventions. Next slide, please. What we found is that almost all the interventions and all that we found were directed towards older children and adolescents. So in fact, there were only 2 studies that had children under the age of 7. So there's a real gap when it comes to younger children. We did find, as is often the case in sort of early days of generating evidence, that the interventions were extremely different and quite difficult to compare. So, for example, some of them focused very much on mother and child relationships where the mother was HIV positive with the adolescent child, where others would focus purely on children and providing support groups within a school context. The types of outcomes that were measured were quite different, and also the way that these different outcomes were measured, even if it was, for example, depression, they used a range of different measures to measure depression. Things like timing of the interventions is also very different. So some of them were 8 weeks long, relatively short. Some of them were 10 months long, which we would think was quite long. And then some of them were followed up, within a couple of months or 10 weeks. And some of them, they kept following up the children up until 2 years later to see if there was any long-term effect. Next slide, please. But we did see a lot of positive results coming out, which is really, really encouraging. So I've got 2 of the kind of main areas where there were positive results, and it's looking more at the psychological side of the mental health outcomes. A few of the studies had reduction in internalizing and externalizing behaviors. There was a decrease in symptoms of depression, decrease in anger, and decrease in anxiety in some studies. And we also saw positive behaviors increasing, so higher rates of prosocial behavior, self-help abilities, and communication. And there were also other positive social outcomes that were noted. Quite a few of the studies looked at school retention, and we found that there were a number of different things that led towards school retention and attendance in school, so actually regular attendance. And also a link with girls not being married early. So we saw a lot of positive things come out of these studies, and in fact all of the studies except for 2 had positive results that they reported. I think from our side, really what this data shows, these data shows that there's a real need for real-world, evaluating these real-world interventions. And it is difficult. Look, it's something that we struggle with as well. That's a lot of the work that we do is trying to look at how we can do this kind of thing. And the Child Community Care Study is very much focused on this kind of work. There's certain things that are impossible in certain communities. For example, it's not always possible to run a randomized control trial with an existing service, particularly if it's the only service for an area. It's very difficult, and there's ethical issues, there's logistical issues that need to be thought about. But at the same time, there are different ways of looking at evaluation. 2 of the examples I put on the slide are the Mad About Art study and then an evaluation of support groups in Kenya. Both of these studies went into the intervention area after an intervention had taken place, and then found a way to compare children who had received the intervention with children who hadn't received the intervention in a way that was quite novel. And resulted in some really interesting results. So I think it's possible. We just need to start thinking about how we can try and fit research into these everyday community level programs. Next slide, please. The next slide, which is still coming up for you, is basically a table of some of the different studies that we included, and I'll be happy to talk further to this afterwards. because I think it is, if anyone has got particular questions about some of the programs. One thing which I always find interesting about this this exercise is that we had two studies which did very similar interventions, and you'll see them about halfway down the page by Denise Halfors, this 2011 and 2013, and they did a very similar intervention in Zimbabwe and in Kenya and found very positive results in Zimbabwe, but then didn't find the same positive results in Kenya. And I think it's always important that we remember that just because something works in one place, it doesn't mean that it will necessarily work in another community in exactly the same way. So as much as we're trying to find evidence that we can generalize as much as possible, it's still very early days, and we still need to try and understand what the different factors are and what might make a particular intervention work in some contexts and then also not in others. Next slide, please. In terms of how the information can be used in programming, I think, as I keep saying, it is early days. There are a number of new studies, which is very encouraging, but they're still very different, and it's very difficult to compare them at this point. I think there's some general themes that we can take out of what we found. For example, that there are a lot of group-based interventions here. They do seem to be working well. We also can see that when conditional cash transfers, for example, that are delivered through CBO programs or material support for schooling, those studies have also shown positive results. But it is a little bit too early to start saying that these types of interventions are always going to be successful in different contexts. So it's very encouraging, but we're not quite there yet in terms of the number of studies to really have an evidence base. What's worrying for me is that there's very few studies with children below the age of 7, so it really feels like there's a big gap there for, in terms of early childhood development interventions. And I didn't mention this, but a lot of the studies were focused purely on girls. I can check the number, but basically there was a number of studies that only had girls, 100% girls, and there were no studies, for example, that had 100% boys. So it does seem that boys are being a little bit sidelined in a lot of these initiatives. Of course, we have to worry about publication bias, so maybe only the positive studies are getting published, and there are other studies which have had a negative impact or have had no impact either way, which we aren't seeing. But of course, that's something we always have to worry about, and it's difficult to tell if that's happening. And yeah, just generally, I think that the situation we're left with is positive. We do have growing evidence, and there are some early lessons that we can learn, and all we can hope is that these early efforts will be built on further, and that we'll, in 10 years' time, we'll have lots and lots of different resources that we can draw from. That's next slide. I think that's, yeah. So in terms for us and research questions as researchers, what should we be looking at? It's great that there's the support for investing in evidence-based programming, and that's something that we're trying to get more involved with as well. As in terms of researchers, what we really need to be thinking about is how we can design our evaluation efforts to fit into community organization programs, as I mentioned. And also, I think further work that we need to do is how we can try and get our early evidence and our early findings more securely into policy and advocacy moving forward. Thank you. That's all.
Thanks very much, Sarah. That was an excellent presentation and has huge amounts of food for thought. The way that I would like to handle this now is I would like to allow Fran to answer the questions that she was given. But before I open the mic for Fran, I want to just read a couple of questions for Simon that are coming up and give Simon a chance to think about those before he answers them. And then I've got a couple of questions for the group of researchers and the audience as well that I would like to share. So for Simon, thanks for the presentation. Did you find any difference in protective behaviors between adolescents who had better knowledge of HIV transmission and those who had less knowledge of HIV transmission? And then the second question is, could you also comment on how knowledge was measured and what you consider to be reasonable or good knowledge of HIV transmission? So how was your measure around HIV transmission calculated? Are those the two questions for Simon? Okay. So, Simon, if you can think about those answers, I just want to give Fran a chance to answer the questions that she was asked, and then I'll turn the mic over to you. So, Fran?
Great, thank you. Thanks for these really good questions. I'm going to start with the second question about the intervention, how long it was, and so forth. So the intervention wasn't an intervention imposed by us. In South Africa, there are universal child cash transfers that every family who is a South African citizen can access if they have children under 18 years old. The threshold is, I think, something like a maximum income of 4,000 rand per family per month, something along this line. So they are conditional in the sense that you have to meet the minimum threshold or be under a certain monthly salary, but everybody can access them, so there are no conditions imposed other than that. We were lucky in the sense when we collected our data is that the South African government had made this grant available for 0 to 14-year-olds, and by the time we were collecting the data, they just changed the legislation to extend it to 18-year-olds. So there were a lot of children within our sample who were not, or a lot of families who were not yet getting grants. And so it was basically a natural experiment with a national intervention that was happening at the time. So in order to qualify as receiving a child grant for this analysis that we carried out is that you had to receive the grant at the baseline and follow-up data collection, and basically have incidents of transactional sex or age-disparate sex at the second time of data collection. So we were looking at how the receipt of the grant at both time points was affecting your HIV risk behavior. Does that clarify the question?
Yeah.
And yeah, okay. And the second question was about boys. So we didn't see an effect on boys, and the person who had asked the question asked whether it was possible that boys pay for sex with girls, and that we were seeing the trend going in the opposite direction. For boys, we saw a trend for less age-disparate sex, but it was not statistically significant, and we saw a trend for slightly more transactional sex, but again it was not statistically significant. But this basically meant that boys were being paid to have sex with somebody. It was not that they were paying somebody else. So I can't possibly answer the question because our data, we did not ask whether boys were paying for girls to have sex with them. It is, I mean, there is a possibility that that's the case, and I think that's something that we should probably look at more. But mostly with our experience from the fieldwork, it looks like the transactional sex that is happening with older partners rather than with partners within the same age group. I can't really say, but I think it's a really good question. I think we should look at that further.
Thank you very much, Fran. That was excellent. Thank you very much for clarifying those questions. I just want to open the floor for Simon to get a chance to answer his questions, and then I'm going to open the floor to some general questions. So Simon, I'm going to give you a chance to speak now.
Okay. Thank you. Okay, so my questions were, I think, mainly about knowledge about HIV transmission, how it was measured, and whether people who had more knowledge had lower risks of HIV. So this wasn't actually something which was addressed in the analyses that we've done just now for the RIATT project. So I've been rapidly scrambling back to try and find other earlier papers analyses that we did. But what we do is we construct something called a knowledge index. We have a set of questions in our questionnaire about different ways in which HIV can be transmitted, things which are protective against getting HIV infection, and so on, and just general knowledge about HIV, about how long it takes from when you get infected to when you develop AIDS in the absence of treatment, and so forth. So based on that set of questions, we give the answers, each answer a score, and add them up, and we create an index. So basically that's the way that that knowledge was measured. We did an analysis of this back using the data from the first round of the general population survey. So this is way back in the late 1990s, 1998 to 2000, and the analysis we did, that's been written up anyways, was mainly focusing on girls, on female adolescents, and we did find that girls who had greater knowledge about HIV were more likely not to have started sex, and were more likely to have avoided having become infected with HIV at that point in time. There's a lot of debate about in this kind of area. I mean, generally speaking, perhaps we could say that our results here were a little bit surprising. That people generally, a lot of the time, knowledge isn't directly associated with adoption of safer behaviours. It's seen as being a necessary requirement, but it's not always sufficient on its own. One has to have other interventions to address some of the social context in which risky behaviour is taking place and so forth, in addition to improving people's knowledge to make a difference in helping people to adopt safer behaviours. But in our own data at that time, we did actually find some direct associations between knowledge and adoption of safer behaviours and reduction in HIV risk. That answers the question as best as we can.
Thanks very much, Simon. That's very, very helpful. I always use the example that we know that we should all be wearing seat belts, but that doesn't make us necessarily wear them all the time. So yes, there's never a direct link between knowledge and behavior, which is what keeps us, you and me, in business quite a lot. So we have another question sorry, I'm having to lean over a couple places, so I'm hoping people can hear me. We have one more question that is to all three panelists, which is, what are the key drivers of orphans? Oh, sorry, this is for Simon. Sorry. What are the key drivers of orphans moving from household to household, and how can this be addressed? And before Simon answers that question, I would just like to throw out a question to the panelists and to the audience as well. So I'd like to hear as well from the audience, which is, in all three presentations we heard about the fact that there are no boys. What about the boys? What's happening with them? They're not included in studies. They seem to be not in our programs when we're studying programs from Sarah's work. So I would just like to sort of throw that out there generally to say, what do we think, both as researchers and as programmers, we should be doing about our young men there? So Simon,
Okay, thank you for the question. So in this particular analysis, it seems that I'm just looking at the paper that we've drafted on this. We didn't manage to get specific answers on the reasons for migrating from everyone. We only got for some reason, we only got specific answers on about, only analysed the answers about just over half. But the reasons given for those half were, the largest reason was the mother or caregiver having died or being sick. In some cases, I guess particularly for girls, the adolescents having got married. In a small number of cases, the child has actually moved to go to a new school. So actually, presumably they hadn't dropped out those children, but the reason that they've moved is to go perhaps to a boarding school or something like that. Or sometimes people I think in Zimbabwean culture sometimes they might move to stay with a different relative to be closer to what's considered to be a better school. There were a few cases where the caregiver was said to have recovered from an illness, and therefore the child had moved back to stay with the caregiver. There were one or two cases where the child was reported as having been mistreated by the current caregiver. That had prompted the move. One or two cases where the mother herself had moved to a different area and the child had moved with the child. And then there were some cases where the child had left school due to insufficient funds for fees, so perhaps they had to drop out of school completely and they'd moved somewhere else and they tried to find work. One or two cases where they left school due to failing exams or passing exams or having completed school up to a certain level and then they decided to leave. So it's a variety of different reasons, but the largest single reason was mother or caregiver's death or illness.
Thanks very much. So what I would like to do now is I'm opening the floor again to this question about the boys as my first question to both the audience and the researchers who have presented. I think the easiest way to do this is if I just do it in the order that the presentations were done. So if Fran, you can give your thoughts about the boys, followed by Simon, followed by Sarah, then I'll open it up to comments. I'll read out the comments that are coming in from the floor. But again, just really thinking about the fact that we don't seem to be reaching them or thinking about them in the same way as we have been thinking about girls. So go ahead, Fran, and if you can share your thoughts, and then I'll move on to Simon and Sarah.
Great. Thanks, Lisa. It's a really fascinating question. I think part of the reason why we're not particularly thinking about boys, I mean, we tried looking at them and we couldn't find an impact of the cash grants, but could find an impact of cash plus care. But I think part of the reason is also that HIV infections in adolescent girls are on the rise, whereas in boys they seem to have stabilized somewhat. And so most of the concern, I think, at the moment is around adolescent girls. I also think that part of the problem may be that boys are a little bit more tricky, that they're more complicated, and that they're less obvious choice for interventions, it seems, within HIV risk behavior, because I think many of the, for example, interventions that look at delinquent behavior and violence and so forth are specifically only target boys. So I think it's a particular vice of just looking at the girls within the type of research that we do. Secondly, I also I think that part of the whole possibly gender movement sometimes gets pulled slightly out of proportion and just focuses on girls rather than looking at both genders together. And I think a more integrated approach, because obviously boys and girls grow up together and influence each other, would sometimes be more helpful, or often be more helpful. But I think part of the problem is that money gets addressed to empower women or to empower girls, and then the focus is slightly more on girls rather than boys, even though they should really be part of the solution or part of the problem. Does that answer the question?
Yeah, that's great. No, I think that's very helpful. So, Simon, do you have anything to add to that? Simon?
This is Simon, hopefully.
Yeah, Simon, do you have anything to add to that?
Well, yes. In relation to school education, which I suppose was the focus of our presentation, and one point would be that overall levels of school enrollment and attendance amongst boys tend to be higher than amongst girls, kind of in the first place. So there's a lot of greater emphasis on trying to find ways of increasing school enrollment and attendance amongst girls. I mean, in Zimbabwe, overall levels of school attendance and enrollment, even amongst orphan children, are quite high. In the regional context, although there's still scope for improvement. Then I suppose another factor is that, as the last speaker mentioned, that HIV prevalence is already quite high amongst teenage girls, whereas HIV prevalence only really starts to take off for males once you get into the 20s. So I suppose people are looking at thinking hard about what can be done to reduce the risks for girls at younger ages, and the fact that there's a lot of evidence showing that school enrollment and attendance can help to reduce the risk behaviours and HIV incidence amongst girls at those ages, means that anything that can be done to increase attendance and enrollment amongst girls at those ages could have knock-on effects for reducing HIV risks for girls, whereas the association is not so clear for boys. I suppose that means that one needs to think also what are the long-term effects. Does school education have a protective effect for people as they get older, as they get into their 20s and 30s, as well as a kind of an immediate effect whilst they're actually at school, perhaps in their teens? But again, there's less clear evidence, I think, that that's the case for males compared to females, so that might be affecting people's thinking on this. And then people, coming back to point about cash transfers, I think one of the main mechanisms through which cash transfers are helping to reduce HIV risks amongst girls is by helping to keep them in school for longer. So I think those two things kind of work together. Thank you.
Thanks very much. That's very helpful, and a good reminder that the reason girls are out there and boys are less is that they're the ones that are more often at risk. So that's useful. Sarah, did you want to add anything before I ask another question?
Sure. I mean, I just wanted to add, I don't disagree at all with the focus on girls. I think there's very good reasons for that focus. I think I agree with Simon that maybe the long-term impact is something we know a little bit less about. And at the end of the day, I personally think that we shouldn't be so worried about focusing on girls or boys, but rather just having programming that's gender sensitive, that's looking at both sides of the coin. Specifically in our context where we know that HIV has been, the rates have been driven by heterosexual sex. So it does seem counterintuitive to only focus on one side of the coin. What worries me a lot is that, so I did talk about the fact that a lot of the studies we found focused only on girls, but actually two of the studies didn't even report what gender the children were, so which is also worrying because I think we're just sort of forgetting about gender in some cases, and really, yeah, I guess my main thought is that we need to be as gender sensitive as possible, and be aware that there are different issues that affect both boys and girls, and let's not forget about both sides of it.
That's an excellent point, and I just want to highlight one of the things that REPSI is doing from the programmatic perspective. So this came from one of our colleagues who's an audience member, but since I'm a part of this project too, I can speak about it. But REPSI is in the process of looking at a gender-based violence program, a gender-based violence prevention program in Malawi that we've just developed, and we're piloting that work, and it's looking at both a response to girls through a self-defense and sexual health program and a boys component that is looking at helping them understand the negative cultural aspects of promoting violence around males, for males. And then together, those two, after they're both trained, go into a joint group where the boys and girls come together with the adults and go through an exercise that looks at how they can make their community safer overall. So watch the space, because hopefully we'll have data in the next year or so, well, in the next year for sure, on this as a pilot. So it is important, I think, as Sarah mentioned, to start looking at gender sensitive and inclusiveness throughout it, and definitely reporting on gender. And it's true, REPSI is always struggling to try and make sure that gender is accurately reported in all of the data that it's getting coming out. So Yeah. Another question that I have for both the audience and the programming team is something that I think Sarah brought up, but also it came up in Simon's conversation a little bit and also in Fran's, but this idea of, so how do we take advantage of opportunities that are out there we have excellent researchers on the ground and we have really interesting programs that are happening, but they're often not getting evaluated in a way that we would hope that is happening. And so how can we bring these two groups together? How can we marry this in a different way? So I'm going to start with Fran and again move through to Simon and Sarah, but then I really want to hear from the audience as well in terms of, because a lot of the audience is thinking about programming. I can see all the audience members here and I know who you are. So just to think about your own programming work and how you could take better advantage of resources that are out there or researchers out there to sort of bring things together. So from a researcher's perspective, how would you like to be working, given the challenges that Sarah's mentioned around, programs happen and then we have to kind of think around that space to make the evaluation take place. But what are some thoughts about how we can do better, both as programming and as researchers, to bringing those two silos together? So I'll let Fran speak first, and then Simon, and then Sarah, and then open the floor more generally. Go ahead.
I think that's a $1 million question, isn't it, Lisa? I'm not so sure. I think part of it is to, on both sides, to realize that we're all working on the same team, and that we're when we say we want to generate evidence or properly evaluate a program and see whether it works or doesn't work, that that there's no, what we often encounter is a kind of resistance saying, well, we've been using our program for so long, of course it works, a kind of a resistance to actually to question whether something works and why it works. And obviously we're, as researchers, sometimes we're quite insensitive to that. So I guess a better communication about why evidence is important, and how we can incorporate what's already out there and then conduct research on it, rather than having, as researchers, coming up with new things because stuff that is out there has not been evaluated and isn't evidence-based, I guess. That's my best shot.
Excellent response. Can I ask Simon if you have anything to add to that?
You
don't have to.
I think obviously it's helpful, and we should make more efforts to have conversations between the researchers and the policymakers from the beginning, so that the researchers, as researchers, were kind of aware of what the policymakers perceive as being the issues and the areas where they'd like to have more evidence to help them decide what they should be doing, where they should be prioritizing their resources and developing their policies and so on. If that can be achieved at an earlier stage, then apparently it can be more likely that once you have the results, those results will be influential and will be taken on board in developing the policies and the practices going forward. I think we can claim a little bit of success in that, for example, in the cash transfer trial that we were involved with in Zimbabwe, which I think contributed to some extent to the government deciding to establish a national cash transfer program for OBCs within the country, albeit on a somewhat different model than before they had the final results from the trial. But having involved them right at the beginning, I think that was helpful.
Yeah, and one of the things that I would say is that with the data that's been collected in this particular set of briefs that are available on the RIATT site, I would recommend and urge programmers to be using those policy briefs. We specifically asked yourselves as the researchers to not only produce peer-reviewed manuscripts for publication, but to draft policy briefs that could be used by programmers in the field to try and help make that happen. So hopefully those of you who are programmers out there will go to the website and use the data that's been written in a language that would be useful for writing proposals, when you're meeting government to talk about these issues and bring them forward. So that's really, really helpful. Sarah, did you want to say something?
Yeah, I mean, I guess it is the million-dollar question, as Francisca said. It's something that we think about quite a bit in our unit at Stellenbosch. I think there is obviously, this kind of view from a lot of people that research is not particularly useful, not very, it's hard to sort of link research with everyday practice, and what's the point in doing it from one side. From researchers' side, that researchers like things to be clean and be able to randomize and do these simple things to make their lives easier, which aren't possible in a lot of contexts. So I guess there's a need for flexibility on both sides and people being open to partnering. I think it's not. I don't think the two sides of the coin are as distant as they seem, though. I think there are a lot of ways that there's sort of small ways and big ways where research can be integrated into NGO, let's say, programs. For example, through just the regular, monitoring and evaluation systems, looking at the types of tools that are being used and the kind of way that monitoring and evaluation is taking place, for example, within a program. I think there's lots of small ways like that we can strengthen systems to try and get them to generate evidence that can be used. But obviously running massive research projects, in conjunction with community organizations or NGOs is quite expensive. And I think that actually that funders have got a role to play in kind of motivating for NGOs and universities to partner together to evaluate the work that they're doing. And I think, I'm not sure that many funders think about it exactly like that. There tends to be research funding and then kind of, implementation funding as two separate things. But I think maybe funders should be thinking a little bit more about actually not just evaluating within an organization, but actually partnerships between universities or research institutions and then organizations that are running services. And I mean that about community services, but also government-run services, health or clinic-based services as well. I think there's a lot of room for that kind of evaluation.
Offline or online in a different way in some ways. So we're going to open up this discussion and allow it to be continued on LinkedIn. RIATT has a LinkedIn site. And so we would really encourage you to keep this dialogue going for another couple of weeks on the LinkedIn site. So if people have additional questions that they want to ask the researchers, and also start a conversation amongst yourselves around how to improve the work that we're doing on all levels and thinking about these issues. So if you can go to the LinkedIn site and look up RIATT, there will be a discussion that started around this issue. And on their website, we will link it to the LinkedIn conversation to allow for discussion. So with that, I want to thank each of the presenters and also the audience. You were very helpful in your questions. But also, I think this really stirred up a lot of really interesting information and thoughtful ways of thinking about moving forward in terms of collecting good data and how it can be used to affect policy and programming. So we're really grateful to the researchers who've collected the data and who generously thought about creatively looking at their data to provide secondary data analysis for this RIATT funding that was put together. And don't forget to make sure that you go to the RIATT website. There'll be an email sent out to you that allows you to, that will tell you when the webinar is up, and if you can send that to other people along with the policy briefs, you'll be helping to spread this conversation even wider. So thanks very much for your time, and have a good rest of your day.